Good afternoon, everyone, and welcome to our webinar this afternoon on the respiratory function and COVID-19. Why do we struggle to breathe? We are so excited to have so many of you joining us today. We really thank you for coming online and joining us for this virtual webinar. And we really do hope you're going to get a lot from it and really enjoy it. My name's Jacob Brown, and I'm going to be hosting the session today. And I'll soon be joined by Dr. James Buckley, who will be delivering today's lecture. Dr. Buckley teaches on our Biomedical Sciences course at St. George's, and his research interest includes respiratory immunology and pharmacology, as well as factors associated with the student experience in higher education. James, would you like to pop onto our screen and just say hello to everyone?
Good afternoon, everybody. It's nice to get a chance to talk to you all, and yeah, I look forward to speaking to everybody.
Thanks so much, James. Also joining us today is Charlene, who is a third-year biomedical science student, and she's going to be in the background helping to answer any of your questions today. Charlene, do you want to pop on as well?
Hi, everyone. I'll be here to answer any questions about the life at St. George's.
Thanks so much, Charlene. So throughout today's lecture, we're going to be asking you lots of questions, and we'd really love it if you could interact with us using your question box on screen where you can type your answers in. We also encourage you guys to ask us any questions you have about the lecture or the Biomedical Sciences course in particular. And if we do have time at the end of the event, we'll put some of these questions to Dr. Buckley. If we do run out of time, though, we will make sure that we'll come back to an answer via email, and that'll be within the next few days, and we really will do our best to make sure that no question goes unanswered. And the final point, just before we kick off today, is to let you all know that this webinar is being recorded, and you will be sent an email after the event that contains a recording of this for you. Brilliant. So to start off today, I'm going to give a really quick introduction to St. George's. So we are the UK's specialist health university, and we share a site with St. George's Hospital, which makes us really distinctive as a medical university. We were established in 1752, and so we have over 250 years experience in health sciences education, training and research. St. George's Hospital was originally located near Hyde Park in central London, and you can see the black and white photos on the left-hand side of the screen showing that. But in the 80s, we moved to Tooting in southwest London, and the coloured photos on the right-hand side show St. George's today. I'm sure many of you are already familiar with St. George's, and you may have even watched the hospital on 24 Hours in A&E in Channel 4. And I'm sure you can see that at St. George's University, our students are really immersed in a healthcare setting. And we think that's a real benefit for anyone who comes to study with us. We've got a number of facilities on site on our campus, such as an extensive library, an on-site dissection room, pathology museum, student union bar, and dance studios, just to name but a few. If you'd like to explore the university in more detail, please do visit our website where you can see more information about what we have at the campus. So today's lecture will be providing you with a taste of what it's like to study on our Biomedical Science BSc course. This is a 3-year degree which provides insight into the biology-based science behind health, disease and medical intervention. If you enjoyed today's lecture and want to find out more about the course, we recommend that you visit our website and look at the course detail pages. You may also choose to watch the recent recording of our Introduction to Biomedical Sciences webinar, and this is where our subject specialists shared their insights about the course and more information about the opportunities that can present you as a student. And that can be found on our webinars webpage. However, before we wanted to move on, I also wanted to share with you a quote from one of our students on the Biomedical Science MSCI course, which is also another opportunity you might want to explore a little bit further. What I think you can see from Hafsa here is that she really highlights the real flexibility that the Biomedical Science course provides. And you have the opportunity to specialise in one of 11 specific areas. As well as this, you can see that she discusses about the new skills and experiences that students develop on the course, which I think is a really exciting proposition. So without further ado, I'm going to pass over to James, who's going to be taking you through today's lecture on the respiratory function and COVID-19. James, I will pass you control now.
Thank you very much, Jacob, and good afternoon, everybody, again. Let me just bear with us 1 second.
Should be with you now.
Yeah, got it. Cool. Cool, right. So, Jacob, can I just confirm you can see the right slides and everything?
Yeah, that looks brilliant.
Brilliant. Right. Thank you. Thanks, Jacob. So good afternoon, everybody. My name's Dr. James Buckley, as it says on the screen there, and as introduced a second ago. I'm a senior lecturer in physiology within St George's, and I teach on a number of programs, including the biomedical science program, which is what I essentially want to give you a taste of today. So the particular topic that we're going to be the subject of this kind of session or lecture is obviously one that's incredibly kind of current and important at the moment in terms of COVID-19 and the pandemic, obviously, which obviously aware of that we're in, and particularly relating to the function of the respiratory system and the physiology and pathophysiology involved in COVID-19 infection, and particularly looking at why is it that the respiratory system, our lungs and airways, are affected by following coronavirus infection and the COVID-19 disease, and why is it that it has such a kind of devastating effect in some patients within the respiratory system, and why those patients really struggle to breathe, end up having to be ventilated, and potentially even die. And so that's going to be the theme and main subjects that we're looking at today. And so just to give a brief introduction to some of the context, so obviously unless you've been living, I don't know, in a cave or something or under a rock, you'll obviously be aware of the kind of enormous impact that the current pandemic has had, both in terms of everyday life, economics, but in terms of kind of healthcare and kind of the impact of disease on a lot of individuals. And so just in terms of kind of where we are, this data from a couple of weeks ago when I was kind of putting this together, since the start of the pandemic, about 18 months ago, or coming up to 2 years maybe now, there's been over 250 million cases worldwide. That's a really underestimate, with over 5 million deaths associated with infection with the virus. And in the UK alone, close to 10 million people have been affected so far with all that we know with COVID-19, with coronavirus. Within the pandemic, with over 140,000 deaths, and you can see on this figure here just the extensive impact that it's had on countries all over the world. And the whole kind of culprit is this particular fellow here, the severe acute respiratory syndrome, coronavirus 2. It's a mouthful, so it's often abbreviated to SARS-CoV-2. And so that's the virus that causes the disease and symptoms associated with the pandemic, which is what was termed COVID-19, is the actual impact of the virus, the disease associated with it. And the impact of coronavirus disease, so again, the disease that's caused by that particular virus on individuals, has been found to be highly variable from people relatively asymptomatic, mild disease, all the way up to a significant proportion, relatively kind of a minority, but a significant proportion of patients that really do become seriously ill and, as those figures suggest, die following infection because of the impact of the virus on their physiology and their health. And although the disease impacts on multiple and a range of different organs and tissues, cells throughout the body, it appears that the respiratory system is particularly susceptible to the virus and its effects. And it appears that respiratory failure is the most common cause of serious illness and mortality death, with patients often struggling to breathe, developing severe hypoxemia or a deficient amount of oxygen within their blood, so not enough oxygen getting to their cells and tissues. And ultimately, many patients die of respiratory failure. And that's where you have the classic situation of somebody needing to be ventilated, put on supplemental oxygen, and really kind of quite extreme measures to actually try and keep them alive. And so what we want to think about, kind of a theme that runs throughout this session, is kind of how and why does, and hopefully again what this lecture will answer is how and why does coronavirus infection lead to respiratory failure? How is it that it impacts on the normal physiology of the respiratory system so it has such a devastating effect in some patients? And so to illustrate some of the kind of more abstract or theoretical aspects of the physiology and pathophysiology that we're going to be talking about, it's useful, I think, to have or to illustrate it with a kind of realistic clinical scenario, which we've got here. So If you imagine the following case, so John, who's a 69-year-old male living in Tooting, London, so nearby to where I am now, near St George's, starts to feel unwell. He feels just awful and starts to exhibit classic kind of flu-like symptoms, including a headache, significant fever, and a cough. Now, 24 hours later, his condition has really deteriorated significantly. He feels extremely fatigued and tired, and he's starting to breathe in a kind of elevated and laboured manner, finding it difficult to get enough breath in. He feels like he's constantly short of breath, and as a result, his family are worried about him, and they call for an ambulance. As a result, John is transferred to St George's Hospital, basically where I'm speaking to you from today, where he undergoes a series of investigations and tests, and he tests positive for the virus. His doctors also take a range of clinical readings, including the following, some of which are included and displayed there, including his blood O2 blood O2 saturation, which is 80%. In brackets, I provided the kind of normal or healthy values. So blood O2 saturation is the level of oxygen present within his blood, expressed as the percentage of hemoglobin sites, of total available hemoglobin sites within a unit of blood that are currently oxygenated. And so in a normal healthy situation, such as you sitting at your computer at home or me now, we would expect that to be well over 95%, 98%, for example, close to 100% saturated, basically. And where it goes below that, it becomes a real problem and is indicative of a real kind of respiratory problem with the respiratory system. And so John's got 80, which indicates there's an issue there, clearly, in getting oxygen into his blood. We then have the reading called PaO2 with a small a. What that is the pressure of oxygen within his arterial blood, okay, so which is 8 kilopascals. And we'll come on to exactly what these units mean in a second, but you can see relative to the normal range, it's deficient. There's a lower than normal or healthy amount that you would expect in a healthy patient. So not enough oxygen within his blood or relative to healthy value. And then his carbon dioxide value there, 5.5 kilopascals, which is kind of in the normal range, maybe slightly higher than normal, but not remarkable. And so the kind of questions that we want to think about and that we're going to hopefully answer in the session are thinking about being able to explain John's symptoms in terms of the physiology of the respiratory system and the body generally, and the way the disease works. Why is it that COVID-19, infection with the coronavirus and the disease it induces, leads to hypoxemia, not enough oxygen within his blood, as you can see there, and respiratory failure? Secondly, why is respiratory system function particularly susceptible to disruption by COVID-19? Why is that the most common cause of death potentially in patients with COVID-19? And then finally, I put the kind of thinking about things like how would the respiratory system and body more generally respond to these sorts of symptoms and readings, physiological situation going on here, in an attempt to kind of compensate for the kind of hypoxemia that's present here or the effects of COVID-19. And so just from kind of where you are now in your kind of education, if you've done biology or kind of just what you know about physiology and coronavirus and things like that, you might be able to answer some of these questions or have some general idea. Hopefully, from what we're going to talk about in this session, you'll get a more nuanced and kind of be able to understand and be able to communicate it in much greater detail and with much greater nuance and complexity. And we'll come back to this at the end to see how we do. So just to start off, it's useful to kind of think about a bit about the background physiology of the respiratory system before we think about the specific applications or changes associated with COVID-19 or virus infection on the respiratory system. And to start with, what I want to think about is, or get you to think about, is what is the fundamental role of the respiratory system within the body? What is it that is the primary goal of the respiratory system, so that if it's not there, it creates a problem? Clearly, the respiratory system has, several different roles that it plays that are important. So, for example, in speech and communication, I'm talking to you now. My respiratory system, breathing, enables air to pass through my vocal cords. It creates vibrations involved in speech, which is obviously important. Respiratory system also involved in the production and metabolism of certain biomolecules, such as angiotensin converting enzyme, for example. However, what's its primary goal, would you say? And actually, to start with, it's worth saying, so there are a number of different interactive parts with this. I please encourage everybody to kind of have a go and answer, and I'll kind of respond to the answers that you give. Just to get us going, Could you just type hello or hi or something like that, just so I know that I can communicate with you properly? If you wouldn't mind just saying hi, hello, something like that. Brilliant, we got the first person's done it, that's great. Cool, thank you very much for that, that's really, really useful. So thinking about this question here, what would you say is the fundamental role? What is it the respiratory system does in terms of the overall function and physiology of the body? And so if it's not there, why does it create a problem? What do you think? Cool, so thanks very much. A couple of people have started to answer. So somebody said uptake of oxygen, which is absolutely correct, definitely, as we talked about when we saw COVID there. You know, when there's dysfunction, not enough oxygen gets in. Why is it that we need oxygen as well as something to allow us to breathe and things like that? Why is it that we need to uptake oxygen? And somebody said quite rightly there, again, apologies, they go quite quickly, so I missed some of the names. Somebody said to produce energy, which is brilliant. That's fundamentally the thing that I was going for here. Fundamentally, the cells in our body, to do the things that they need to do in terms of their cellular function, many of them require energy. Okay, so for example, if it's a muscle cell contracting, or I don't know, to reproduce the cell, to create certain biomolecules, to pump ions against their concentration gradient in terms of active transport, it all requires energy. And the body produces that energy in the form of ATP, which is sort of like a currency that it uses to spend on metabolic processes. And aerobic respiration requires oxygen and produces carbon dioxide. So it needs oxygen and it produces carbon dioxide. Somebody quite rightly said there, thank you, Gustav. And the oxygen around us is obviously an extremely excellent source of oxygen. There's plenty of oxygen there, and it's a massive space into which our excess or the produced carbon dioxide from metabolism can be dumped, expelled to. However, our bodies are ultimately too large, human bodies are ultimately too large to just rely on simple diffusion of gases from the atmosphere to all the cells in our body. There are certain very, very small organisms that can just rely on just diffusion. They don't need a respiratory system because the oxygen and carbon dioxide or whatever respiratory gas can just diffuse one way or another. Therefore, our body requires some way to get oxygen in sufficient quantities into those cells, and so to get carbon dioxide out in the other opposite direction. So by working together in conjunction with each other, the respiratory system and cardiovascular system work together to move oxygen from the atmosphere to the cells where they need it for energy production, and move carbon dioxide in the opposite direction. If we look at the next slide here, it kind of talks about this journey or the various steps, key stages of the process involved in that process of getting oxygen from the atmosphere to tissues, kind of summarized in this figure here. First, there's ventilation. What we mean by ventilation is ultimately kind of breathing. It's moving fresh air or quantities of air from the atmosphere to our lungs and then back out again. Okay, and we'll go into that more in a second. So that gets oxygen from the atmosphere to the alveoli within our lungs. You then have what's called gas exchange, where that oxygen diffuses from the alveoli, where it's entered via ventilation, diffuses via gas exchange into the blood, with carbon dioxide moving in the opposite direction, down a concentration pressure gradients or concentration gradients. The oxygen that's then blood binds to hemoglobin and is transported, distributed throughout the body. So it goes to the cells that need it essentially. And then once it reaches the particular areas of the body, the tissues that need it for energy, oxygen diffuses from the hemoglobin, where there's relatively high amount of oxygen, to the relatively low level of oxygen within the cell. So you get another gradient there. And so that's generally how oxygen gets from atmosphere to cells, with carbon dioxide then essentially using the same process, but in reverse, ultimately. However, a bit of a difference is that the vast majority of carbon dioxide isn't transported by hemoglobin. A small amount is, or a relatively small amount is, but not the majority, like with the case of oxygen. With oxygen, even really almost all of it is transported back to hemoglobin. It's heavily reliant. If we just zoom in a little bit in terms of the first couple of steps of this process, and look at the kind of what's going on in terms of when we breathe and ventilation, and the impact and the relationship between that gas exchange and the level of oxygen reaching our blood. If we just conceptualize or consider a relatively very simple model of airways, lungs, and circulation, as you've got here. Just imagine an airway, imagine one airway, one lung, or one alveolar unit, and then the blood supply that innervates that particular alveoli or lung, or whatever you want to call it. So in the ambient air, in the atmosphere, the air that we breathe, you have a relatively high amount of oxygen and almost negligible, almost no carbon dioxide. We breathe that in, and by the time it reaches our lungs, okay, you've kind of gone down to mixes with the air already there. It's gone to about the values there. I should say that the units there in terms of kilopascals are a unit of pressure. Generally, when we're talking about the physiology or the impact of physiology or the behavior of gases, we generally talk about pressures rather than concentrations to express how much of the gas there is in that particular place. The reason for that is that pressure is a better fit for the behavior of gases because concentration isn't perfect, but it essentially means the same thing. It's just how much of the gas there is there. If there's 21, that's more than 14, so it's just a relative level. The reason why it goes down from 21 kilopascals in the atmosphere to 14 by the time it gets into our lungs is because when we breathe out, we don't breathe out every single last bit of air within our lungs. There is a certain amount always left over, depending on how much the extent to which we breathe out, things like that. And so there is already relatively stale air, relatively low levels of oxygen within our lungs. And so when we breathe in, fresh air that we breathe in, high amounts of oxygen mixes with that air that's already in the lungs. And by the time it mixes, you get these sorts of ranges. And so then if you look at the level of oxygen and carbon dioxide within the blood that innervates that alveolar unit or whatever, however you want to frame it, you can see that the level of oxygen in venous blood on the left-hand side is about 5 kilopascals, something like that. It varies, but these are just kind of ballpark figures. So carbon dioxide 6, oxygen 5, saturation percent, something like 70%. And so you can see that when that blood flows through and innervates, goes past the alveoli, there is a pressure gradient from the air in the alveoli and the blood in the circulation. And so you'll get oxygen moving from down that pressure gradient from the air in the alveoli to the blood in the capillaries, the pulmonary circulation. Okay, and carbon dioxide moving in the opposite direction. And so by the time blood goes past, innervates and goes past, and it comes into contact with the alveoli and then goes into the systemic circulation, back to the heart and the rest of the body, you can see that the levels of oxygen and carbon dioxide have essentially equilibrated with the level of those oxygen and carbon dioxide within the alveolar air. And so you've reached the saturation of oxygen of about 90%, over 95%, highly oxygenated, so that oxygen can be distributed throughout the rest of the body. And so a key thing to get from that is that the level of alveolar ventilation, so the more you breathe, okay, in terms of the rate per minute, the more that the air within the alveoli will start to look like ambient air, okay, because you're getting more fresh air in per minute or unit of time. And so that then impacts on the size of the pressure gradient of oxygen between the alveolar air and the blood. Okay, obviously you breathe enough, that pressure, again, the air will look in the alveoli will look more like the venous air, and there'll be a smaller gradient and less gas exchange. Cool. Another thing, just before we get on to kind of some of the disease aspects and some of the ways respiratory system function can go wrong, it's worth thinking about. I don't think there's an intuitive way when we initially kind of think about that process involved in gas exchange or diffusion. Kind of just imagine it. I know I did for a long time. Just imagine it as almost like the molecules of oxygen just jump magically from the air in the alveoli to the hemoglobin, and it's just sort of one step. Whereas in reality, in order to get from that alveolar, the air in our alveoles or in our lungs, to the blood and the hemoglobin within a red blood cell, there are a number of different structures, media through which that oxygen has to pass and ultimately diffuse. And so you can see there just the number of different structures. If you imagine the top being the airspace, so the air in the alveoli, then you have the fluid layer of the alveoli lining the alveoli, the membrane between the alveoli and the blood vessel, the wall of the blood vessel, the blood cell, red blood cell, then the hemoglobin. And so there are multiple steps within that process that the oxygen has to go through. The key point in highlighting that, as we'll come back to later, is that if any of these particular structures change significantly, that's going to potentially impact the way in which, or the rate at which the oxygen diffuses through those structures. Okay, so having covered a little bit about the basic physiology of the respiratory system, we now want to think about how can the function of the respiratory system, or respiratory function, go wrong? If we're thinking about that journey by which oxygen gets from the air to cells, what are the different kind of ways in which that could be disrupted by pathology, injury, disease, anything? What are kind of the broad ways in which that can be stopped or disrupted due to disease or trauma or whatever, would you say? What are some ideas about that? So I'm less looking about particular diseases, but more about what is it that disease or process or trauma or injury, change, whatever, do that messes up that path of that journey from oxygen from the atmosphere to the blood. Cool, so somebody said damaged alveoli, which is absolutely correct. If you damage those structures, it's going to impact. What particular aspect of that process would be disrupted if you injured or damaged your alveoli, do you think? Yeah, so it's a gas exchange, exactly. So we'll come back to that shortly. But what other sort of broad areas, like if you found out that somebody isn't getting enough oxygen into their blood or into their cells, and you had to kind of hypothesize about, well, what reasons might there be for not enough oxygen getting from the atmosphere to cells? What reason could there be? Cool, so somebody said, again, mucus buildup, swollen bronchi, obstructive airways. What would that impact on, would you say? So, for example, many diseases like asthma involve narrowing of the airways. What aspect of the path or the journey from oxygen from the atmosphere to cells would that impact upon? Of course, someone said damage to blood vessels, and again, that's correct, definitely. We'll come back to that in a second. Of course, again, someone said the surface area of alveoli, and again, that's true. Again, we want to kind of think about, in addition to that, that's a good answer, we want to think about how would that impact on the function of the respiratory system, potentially, in terms of how it works. What aspect of the way it works would be impacted? Cool, someone also said carbon monoxide poisoning, where that displaces oxygen on hemoglobin. That's correct, absolutely. Very good. Cool, so thank you for those answers. They're really, really good. And you've covered most of the ones that I'm kind of going to say. What we want to do is kind of classify some of these into kind of broad kind of categories about the ways in which, the kind of broad fundamental ways in which respiratory function can be impacted. And then to start with, you can kind of think about, well, the respiratory system is not going to work very properly if there's insufficient ventilation. So you just don't breathe enough. You can't get enough fresh air from the atmosphere to the lungs at a sufficient rate. Okay, you can't breathe enough, essentially. And again, like you kind of highlighted, there are a couple of different ways in which broadly that this can occur. You can either get person not breathing enough or not breathing enough air per minute or whatever it is, because of either obstruction to the airways. So for example, something like an obstructive airways disease like asthma, where because of mucus or contraction of the muscle within the airways, the airway lumen goes from being, or the size of the airway in the middle goes from being very dilated to relatively constricted, and obviously less air can pass through that per minute. You also, if somebody chokes or something like that, clearly that's going to impact on the degree to which somebody can breathe. Ventilation is going to be impacted negatively. However, you can also have a situation where the person is not breathing enough, where their airways are clear. So for example, this would be where there is not enough stimulation of breathing activity, either because of some damage to the central nervous system and the brain, and so not enough signals are being sent from the brain to your diaphragm, your respiratory muscles to actually cause the movements within your body to breathe. So something like a stroke, motor neuron disease, brain injury, something like that. And you could always also have damage to any of the other kind of part of the necessary tissues involved in breathing. So for instance, spinal cord injury would impact on that, kind of muscular dystrophy, where the kind of muscles involved in breathing and movement of your chest kind of degenerate to the point where you can't actually breathe sufficiently. The kind of second kind of stage would be, well, like many of you talked about, you can have insufficient gas exchange. So you might be breathing enough, but the oxygen that you're breathing in, or the fresh air that you're breathing in, the oxygen within it, can't then, because of pathology, injury, disease, etc., get from the air in your alveoli to the blood. You're breathing enough air, but it then the oxygen doesn't actually get to your blood. It gets to your lungs, but it doesn't get to your blood because of some kind of dysfunction. And again, we'll talk about that later. Then you can also have kind of what I've classified here as transport or distribution dysfunction. So this could either be, as somebody highlighted, something like carbon monoxide poisoning, or something like anemia, where the function of hemoglobin has been impacted negatively. So again, you can get oxygen from the atmosphere to the lungs, you can get it to the blood, but there's not enough free hemoglobin to actually take the oxygen from the lungs to the cells, tissues, etc. that need it. You can also have a situation where, just because of secondary, other unrelated to the respiratory system, cardiovascular system dysfunction, means that there's just not enough blood flowing. So, for example, if you have heart attack, heart failure, shock, or anything like that, the respiratory system might be fine, but if blood's not pumping through your body, the oxygen is not going to get to the cells that need it. And then finally, you can have a situation where everything in your body can be fine, but if there's not enough oxygen in the atmosphere, that's going to be a problem. So, for example, very high altitudes, there's less oxygen, or if somebody's in a kind of enclosed space where there's a limited amount of oxygen and that goes down and they suffocate or something like that. Very good. So that's the kind of broad ways in which somebody's respiratory system might become dysfunctional. What we want to do now is think about, well, what specifically happens in COVID-19? How does COVID-19 impact on respiratory function? And so many of you, I assume, will have some existing knowledge of the fact that, and by the fact that everyone wears masks and things like that, or is instructed to now, the fact that it is an airborne or droplet kind of infection transmitted kind of by the airborne and droplets in our kind of respiratory system that we secrete and other people breathe in, etc. And so when we inhale kind of particles of the virus, they obviously have instant access to our respiratory system and the airways and our alveoli. And in particular, the cells that line the respiratory system, kind of epithelial cells within the respiratory system, express a receptor on the surface called ACE2, angiotensin 2 receptor. And this is the particular receptor or protein that the virus binds to and uses to actually enter human cells. Okay, and so because the respiratory system it just happens to express those particular protein receptors on the surface of the cells, it means that the virus can then enter the cell where it produces more virus, which then spread and infect. You might sneeze, it infects somebody else, but it is also then multiplying inside your body. What this then does, although the virus and the activity of that virus in terms of reproducing does some direct injury to the cells in your body, obviously if your cell is producing virus, it's not doing some of the things that it should be doing potentially. However, really the more significant aspects of the injury and damage to the respiratory system and other tissues that the virus causes is probably more to do with kind of collateral damage to do with the response of one's own immune system or the person's own immune system. Where there is that virus present, the immune system detects that and mounts a response to try and get rid of the virus. However, in so doing, it actually causes damage to cells and tissues within the respiratory system that actually, really damage it and impact its function. You get an acute wave of inflammation following virus injury, in particular in patients that have a really kind of severe kind of impact of the virus. And you get this acute lung inflammation where particular immune cells enter the lungs, or they're already there in large amounts, become highly activated and start to secrete various inflammatory molecules and various toxic products into the tissue and cells within the lungs. And these kind of really nasty products are supposed to destroy bacteria and things like that. However, in this case, they're just being dumped on the tissue. Whilst it'll probably kill some virus or virus-infected cells, it also, the same damages the cells within the lungs, for example, within the alveoli. And as a result of that, it really injures the alveoli in people that are really affected by it, resulting in somebody said before when we're thinking of ways in which you get damage and dysfunction of the respiratory system. Because of that alveolar injury caused by the inflammation in response to the viral infection, you get scarring and fibrosis of the actual membrane lining the alveoli. between the alveolar area and the blood. And similarly, you also induce pulmonary edema. Because of damage to various structures, it allows water to move in higher amounts from the capillaries, the blood in the capillaries, into the surrounding tissues and into the alveolar itself. And as a result of both of these, they impact on and reduce the level of gas exchange that's possible. And as a result of that, mean that you can get less oxygen into the body, cause hypoxemia. If we just take that again and look at kind of a visual representation of what's going on there. In this figure on the left-hand side here, you can see and what's a kind of healthy or normal alveolar kind of structure and function. And on the right-hand side, what happens during the acute phase of a kind of severe respiratory infection. And so you can see there, relative to the normal or healthy alveolus on the left-hand side, on the right-hand side, the injured and highly inflamed, damaged alveolus, you have high amounts of edema fluid present within the lungs and in the interstitial tissue. If you think back to that diagram figure I had before showing the various structures that oxygen has to pass to get from alveolar air to the lungs, if you've got just a massive layer of water between the air and the blood, I think I said lungs before, blood, that's going to really impact and limit the rate of diffusion that's possible to get oxygen into the blood. Similarly, you can see there are lots of immune cells there present, activating and secreting mediators that damage the tissue. And also the membrane and the alveolar wall itself becomes scarred, damaged, thick, less permeable, meaning less oxygen can move through and diffuse through. As a result, you get various kind of physiological changes to the body, and you result in kind of gross changes that you can see in things like X-ray. If you look at the following two X-rays on the right-hand side there, one of them is healthy, and one of them is a patient with severe COVID-19. Which do you think is which? Is the COVID-19, so one's healthy, one's COVID-19. Is the left one COVID, right healthy, or is it other way around? What do you think? So I guess I should introduce by saying the way X-rays work, okay, just thinking about just in broad terms, it generally, the X-rays are deflected by kind of material, so kind of water, tissue, things like that, whereas they aren't deflected by air. And what you're seeing in an X-ray image is the amount of light that's deflected back from the image into the detector. So which do you think is which? Would you say? Which is healthy, which is kind of acute lung injury, COVID-19? I'll just give you a chance to think about that. Cool, so a few people answered, and so yeah, most of them seem about right. So if you look at those diagrams, like I said, if you imagine in a healthy situation, the lungs should be filled with air, right? And so X-rays will pass through the lungs largely without being kind of reflected or anything like that. And so they would appear darker. Where tissue appears lighter, it means there is more stuff there, so water, for example, and damaged tissue. So what's actually the case is the right-hand side is a healthy lung, whereas on the left, and you can see it's very dark, alveolar lungs filled with air, whereas on the left-hand side, you can see much more of a kind of opaque, kind of blurry, kind of lighter fashion. And that is shown by the water and the fluid that is present within the lungs, okay, that's preventing gas exchange potentially. So you can see the extent to which that really occurs at the injury and the impact that it has on respiratory function. Just taking a very kind of quick look at why gas exchange, or what determines the rate of gas exchange or diffusion within the lungs. Don't be scared by the formula. This is just showing you a particular relationship in terms of if something goes up, what happens to something else, or what we need for the most amount of gas exchange. This shows you that the rate of diffusion, the rate of gas exchange, is proportional to your surface area, and this is true for anything, but this is just applied to the lungs. The surface area divided by the distance, i.e. so the bigger the surface area you've got, the better, the quicker, the higher the rate of diffusion. The lower the diffusion distance, the higher the rate of diffusion, and the bigger the pressure gradient or concentration gradient, if you're talking about that sort of thing, the higher the rate of diffusion. And these are just where they're applied to the respiratory system and lung function. And so for really the maximum and effective rate of gas exchange, you need, and so in a healthy situation, you'll have a high partial pressure gradient, i.e. large amounts of oxygen within the lungs, lower relative amounts within the blood. You'd have a very high surface area, which alveoli naturally provide you to their particular structure, and a very small diffusion distance, really very small barrier or membrane between alveoli, air, and the capillary blood. However, in COVID-19 induced, acute respiratory injury or distress, what's called acute respiratory distress syndrome, is basically just where the lungs become very dysfunctional due to the effects of COVID or other infections. We essentially have, as we said before, damage to the alveolar membrane, fibrosis, scarring, thickening, less permeability, which is going to decrease your surface area, available surface area or effective surface area for the lungs for diffusion to take place. You've got pulmonary edema, presence of increased water within the lungs, which is going to impact on the kind of thickness of the fluid layer and the swell, the interstitial tissue between the alveolar air and the capillary blood. It's going to increase your diffusion distance. And as a result of both of those things, the overall effect is you're going to have a massive reduction in the level of gas exchange. And as a result of that, not enough oxygen is going to be able to get from the lungs or the air in the lungs to the blood. Not enough is going to get to tissues. You're going to get hypoxemia, and as a result, respiratory failure. Okay, and that's ultimately, what kills people. If you can't get enough oxygen to cells, your brain, heart, etc., they can't function properly, and obviously those things, kidneys, and obviously those things, the healthy function of those things is, critical for life ultimately. So we come back to and conclude with going back to that illustrative clinical scenario that we started with in the case of John, who's classic kind of coronavirus symptoms, hospitalized, had the readings taken, shown to be hypoxemic. We want to think about, okay, well, based on what we understand now, how can we explain those symptoms? Why is he hypoxemic in this case? Why does that lead to respiratory failure? Okay. And then, obviously it's difficult to, it's not exactly a few words, so it's difficult to answer here. But if you think about, what you would answer to some of these questions based on what we talked about, hopefully kind of, again, based on what we talked about, you can kind of intuit or surmise that because of the inflammation or because of the impact on the virus and it gaining access to the respiratory system, affecting the tissue, reproducing, that initiates an immune response, which then causes essentially high amounts of inflammation and damaging inflammation within the lung tissue that injures, and causes damage and dysfunction to the tissue. That impacts on the structure of the alveoli, the presence of water, makes it less permeable, greater diffusion distance, and ultimately means that the level of rate of gas exchange is severely reduced, meaning you can't get enough oxygen into the blood, which then can't get to the tissues. In terms of why the respiratory system, or why respiratory system and respiratory system function is particularly susceptible to disruption with COVID-19, and why that appears to be a main cause of death, based on what we talked about and just other things, again, hopefully you can kind of pick up a couple of things. One of which would be the fact that, well, I guess it's a droplet infection, which is, I guess, not a coincidence. The virus has evolved to be transmitted by kind of droplet because it infects the respiratory system particularly, but it's transmitted by a droplet infection. It gains instant access to the respiratory system tissues, the lungs, airways. The respiratory system epithelial cells express the specific receptor that the coronavirus accesses and uses to binds to and uses to access the cells. And also the nature of the respiratory system tissue means that it's susceptible to injury by the high amounts of inflammation that the virus causes or initiates upon detection. And then finally, in terms of thinking about how the respiratory system or body would attempt to compensate for the effects of COVID-19, what I mean by this is in terms of if we're aware there that the person's hypoxemic because there's not enough gas exchange, meaning you're not going to get enough oxygen into the lungs. what is a way in which you could try to compensate for that? Okay, in terms of the physiology or in terms of an intervention, do you think? What could you do to try and overcome that and get enough oxygen into the blood? How might you, for instance, how would you treat COVID-19 in a situation like this? And how would you treat it? And then also, how might the body respond to it just on its own? What do you think? Cool. So thanks for that. A lot of people have answered and said things about like kind of supplemental oxygen, things like that, and that's absolutely right. Hopefully, most people know that, you know, like we looked at the start in terms of some of those figures. You know, when somebody's in a real situation with respiratory failure, you know, you treat with supplemental oxygen to try and overcome the fact that, because you're trying to compensate for that. If the rate of diffusion has gone down, because gas exchange is impacted, one of the ways you can try to compensate for that is by chucking more oxygen into the lungs. In terms of, if only a certain amount of oxygen is getting from the lungs to the alveolar air to the blood, try and just increase the level of oxygen, and a certain proportion of it or rate of it, it will move at a particular rate. That's effective in some patients, but in others, if ultimately, you know, the lungs are injured to the point where oxygen is just really moving at a very, very low state, regardless of the concentration or pressure or level of oxygen there, it really becomes a problem. In terms of the way that the body would respond in terms of its physiology, what we're trying to get at is the fact that if the rate of diffusion of oxygen is insufficient because of the pathology within, you know, the lungs to actually get enough oxygen into the blood, one of the ways it would do that is, again, try to increase the level of oxygen within the lungs. How might it do that? How would the body increase the level of oxygen within the alveolar air or the lungs to try and overcome the fact that less oxygen is getting from the air to the blood, alveoli to the blood? Cool. And the point with this is that you would increase the rate of ventilation, breathe more. Okay, you try to make the air in your alveoli more like the atmospheric air by breathing at an increased rate, and that's essentially why you have a situation where, you know, the body, in response to the hypoxemia and the low levels of oxygen in the blood, detect that, it senses the level of oxygen within the blood, sends signals to the brain, which tells it you need to breathe more, you need to get more oxygen into the blood, you need to get more oxygen in the lungs. As a result, you breathe at an increased rate, the same way as when you're exercising, for example, you increase your rate of breathing to try and get more oxygen into your body, and the same thing works. And that's ultimately why you know, patients are short of breath. Their body's constantly telling them they're not getting enough oxygen into their blood. You need to breathe more, in physiological terms. However, the more they breathe, sometimes that compensates to a bit, but often it doesn't. So they just constantly feel short of breath. They just can't catch their breath. They need to just breathe in more and more and more. But ultimately, it might not fix the problem, but their body's still telling them that they're short of breath. So it's like, almost like, imagine if you've just done a sprint and you're breathing at a high rate, but then kind of it doesn't compensate. But it's not like you breathe at some point and then it goes down. It's just your body just keeps telling you to do that because it needs to overcome that gas exchange problem. And so that's why, you know, the patients struggle to breathe, and why they have that shortness of breath, laboured breathing. It's almost like they've just done a sprint, but that recovery period never ends, or until the virus infection goes down. Cool. And so thanks very much. That brings me to the summary. And so just to summarise things, we talked about the fact that the respiratory system is particularly susceptible to SARS-CoV-2 infection because of the constituent cells that make up the respiratory system express the receptor, particular receptor that the virus binds to and uses to enter cells, being the ACE2 receptor. Viral infection generates a pronounced immune response within the lungs and the respiratory system, and inflammation with those lungs in certain individuals becomes extremely pronounced and severe, resulting in collateral damage to the lungs, alveolar injury, and pulmonary edema, which in turn ultimately impairs the rate of gas exchange and the ability to get oxygen from alveolar air to the blood, move between the alveolar and the blood, limiting absorption of oxygen, and ultimately causing hypoxemia and respiratory failure. So thanks very much. And at that point, I'm happy to answer any questions that anybody has relating to this. And otherwise, I'll pass you back to Jacob. Thanks very much. and it was lovely to be able to talk to everybody today.
So much, James. Really, really interesting. I'm sure all of our attendees have kind of learned something there. And wonderful to see everyone kind of participating throughout. So thanks so much. If you do have any questions for James, do send them in. We do have 10 minutes or so to get some questions across. So we've had a couple come through already, James. The first one, you spoke around how the 5 steps that COVID takes when it enters the respiratory system. And we had a question around how long or what period of time would those 5 steps actually take to go through, and how does that timescale look on average?
Sure. So if we just go back to that quickly, I'll just very quickly go back to that. So sorry about this. So yeah, if we go back to those stages very, very quickly, ultimately, if you think ventilation, breathing in, that's almost instant, by the way in which the speed the air is. So if you imagine a molecule of oxygen within the atmosphere just around you, you breathe it in, it's already in your alveoli. Diffusion happens relatively quick. Second, but if you imagine a red blood cell moving through the blood vessel going past your alveoli, it moves through it moves from the venous end to the arterial end in seconds, or a second essentially. And so gas exchange has to happen very quickly. Distribution, again, blood flows at an extremely high rate throughout the body. So it's difficult to give an exact figure, but very, very, very quickly ultimately. And where you can sense this yourself, that if you hold your breath or if somebody chokes, it very, very, very quickly causes hypoxemia, hypocapnia. They go blue. That happens very, very, very quickly. So it would be determined, it would be counted or quantified in seconds essentially, rather than minutes or anything like that.
God. We had another question come in. Does mucus production during COVID-19 have an impact on ventilation?
Yeah, potentially. Yeah, I mean, I focused on gas exchange aspects of it to kind of keep it relatively simple. I mean, I think COVID-19, and also it should be said that we really don't understand fully the impact of COVID-19, both on the respiratory system and other areas of the body, and it can be highly variable. So it's difficult to give like a kind of exact case for everybody. However, yeah, definitely in some patients, you get a productive cough because of excess mucus being produced within the airways. And anytime you have that at an excessive level, there's the potential that mucus starts to clog the airway and essentially impairs the size the same way it does in asthma or something like that. And so yeah, potentially. Some patients are different, but yeah, definitely.
We had a question here, and I'm really actually interested to hear this. How long does it take for the lungs to recover from COVID-19? Will they ever actually recover, or will there always be some damage?
Yeah, so the answer is that it depends ultimately on the severity of the damage ultimately. And so, as you can kind of intuit, the more mild the damage, the more possibility, or the greater the probability or chance that somebody will recover, and the quicker it will be. Where somebody gets to the point where they're on a ventilator, close to death maybe, but don't die and come back, often the prognosis is quite poor often. And I mean, it does vary, but it can take a long time, weeks, months, that kind of thing, not days. And to some degree, some the respiratory system can be pretty good in some of the ways it recovers. And so a lot of the respiratory function, again, it depends on a number of factors, but can come back. However, you would expect them probably ultimately to have some negative impact on the respiratory function overall in the long term. And again, a lot of people don't recover ultimately, even if they kind of survive the initial period, because of both the impacts on the respiratory system and other tissues like the heart, for example. In the weeks following, it might be that there's still a risk of death or serious complications or something like that.
God, yeah. We've had a couple of questions come in. Well, we've had actually a lot of questions come in. So anyone who we don't answer, we will, as say, come back to via email. But we had a couple come in about kind of the biomed course specifically. Sure. So one of the questions was, a lecture like this, when would that be kind of taught on the biomedical course? Would it be kind of a
sure. So, yeah, absolutely. I think that's a good question in terms of, so you can kind of think about how the course evolves. So in terms of this, it's not exactly the same lecture I give, but of course, because I try to kind of focus it on a particular thing and make it kind of fit this kind of sort of session. However, this is essentially content, not necessarily directly to COVID, but in terms of gas exchange physiology, respiratory physiology, generally, that you would cover in the second semester. So this will be covered around March in the first year, something like that. And the kind of level is about that, maybe a touch higher. I mean, obviously I've focused on a particular audience or something like that, but around the same level. So yeah, something like this would be, how many months in is that? I don't know, about 6 months in, something like that, within the second year. We tend to cover a lot of the fundamental physiology relatively early, one, because it tends to be quite an enjoyable part of the course for students, and also that then helps to understand a lot of the later content in the course. So within, for example, the second semester, we cover the basic fundamental physiology of the respiratory system, cardiovascular system, kidney, other things like that.
Brilliant. And it kind of, I guess, kind of follows on from that. With how would testing kind of occur with kind of this subject? Is it something that students do as a kind of end of year test? Is it coursework?
Yeah, sure. Yeah, absolutely. So in terms of assessment again, it's hard to give a kind of universal answer that applies to everything, but let's just take this as an example. It's assessed in a few different ways. So there's in-course assessment. So part of it's done by coursework, part of it's done by like examinations and things like that. So in terms of coursework, that would be linked to their particular assessments, of course, that's linked to certain practical sessions that would take place within the module. So for example, you might do a practical on, I don't know, particular aspects of cardiovascular function, and there would be a kind of small assessment, either a quiz or some small piece of writing or presentation, something like that associated with that. And so that would be the in-course assessment with the different practicals within the module or different parts of the module. And then probably the majority of it would be examinations, and there are a few different types of questions that we use. So for example, in that physiology module in the first year, we use a range of questions to specifically examine a lot of different aspects of science, or the way that that's communicated or understood, and also to kind of enable different types of students or different types of people to kind of express themselves sufficiently. So for example, that semester 2 exam for physiology would involve some what we call SBA questions, which are essentially multiple choice questions. So it would be a proportion of those, a certain amount of those, a certain amount of what we call short answer questions, which are kind of like the normal ones you get at A level or GCSE, that sort of thing, that kind of thing where it's a question and a paragraph or a sentence or something like that is the answer. And then there's also what we call a long answer question, which is a kind of a piece of extended writing, not as long as an essay or anything like that, but a kind of, I don't know, a page or two, something like that, of writing on a more kind of discursive topic, rather than just what's the name of this or like what's this. It's more thinking about kind of more of a discursive aspect that involves multiple topics.
That's really helpful, thank you. And as I say, thanks so much everyone for sending in all of your questions. We will make sure we come back to them from email. James, if I could just ask you to skip right to the end of the presentation on the slide.
Absolutely. No, yeah.
That'd be brilliant. Before we finish up today, we just wanted to say a big thank you to everyone for obviously attending. Just on that last one, thank you, James.
Yes, sir.
A big thank you to everyone for attending, and we really hope you've enjoyed the session. If you have more questions about St. George's as an institution, you can use the study app email address or phone number there to get in touch. As we mentioned earlier, this is a biomedical science BSc kind of taster lecture, so do look on the website if you've enjoyed today and have a look at what that course involves and a bit more information around the course content. We also have a really exciting webinar coming up this time next week, so Wednesday 8th December 4 p.m. till 5 p.m. again. Focusing on life-saving drugs 24 hours in A&E. So you will be sent, if you haven't already registered, please do, you'll be sent a kind of link to that after this event. But thanks so much for joining us. As I said, do pop your questions in if you have any final ones, and we will come back to you via email. Big thanks to James and Charlene, and for everyone for joining us today. And we will hopefully see you all again soon. Thanks.
Cool. Thanks everyone, really nice to talk to you today.